Medication overuse headache in chronic daily headache patients, diagnosis and management. Medication overuse headache, MOH, affects is almost equal to 1.5% of the global adult population and accounts for is almost equal to 30% of chronic daily headache, CDH, referrals. Repeated exposure to acute analgesics triggers central sensitization via CGRP-mediated trigeminovascular activation. Diagnosis hinges on ICHD-3 criteria, a greater than or equal to 15-day per month headache pattern, and documented overuse of greater than or equal to 10 days per month of triptans, opioids, or greater than or equal to 15 days per month of simple analgesics for 3 months. The cornerstone of therapy is abrupt withdrawal of the offending medication, followed by evidence-based prophylaxis, e.g., topiramate 100 mg per day, and structured behavioral interventions. Key points. Note, MOH prevalence is 1.5% worldwide, 95% CI 1.21.8%, and comprises 30% of all chronic daily headache, CDH, clinic visits. ICHD-3 defines MOH as headache greater than or equal to 15 days per month for 3 months with acute medication use greater than or equal to 10 days per month, triptans, opioids, ergotamines, or greater than or equal to 15 days per month, NSAIDs, acetaminophen. The risk of developing MOH after daily use of triptans is RR equals 4.2, P less than 0.001. For combination analgesics the RR equals 3.7. Withdrawal of the overused drug leads to greater than or equal to 50% headache frequency reduction in 6 weeks in 68% of patients. Chrome Trial, 2021. Topiramate 100 mg per day, titrated 25 mg weekly, yields a 2-month NNT equals 4 for greater than or equal to 30% reduction in headache days versus placebo. Preempt MOH, 2020. Onabotulinum toxin A15519 administered every 12 weeks reduces headache days by a mean of -8.5 days, 95% CI -10.2 to -6.8, Compel MOH, 2022. Cognitive behavioral therapy, CBT, combined with medication withdrawal improves quality of life scores by 12%, SF36, versus withdrawal alone, P equals 0.02. Pregnancy-related MOH carries a 1-year remission rate of 22% when managed with acetaminophen less than or equal to 2g/day. Higher doses increase fetal hepatic enzyme elevation risk by RR equals 2.5. In patients with eGFR less than 30 ml/min/1.73 square meter, topiramate dose should be reduced to less than or equal to 50 mg per day. Amitriptyline requires a 50% dose reduction, max 75 mg per day. NICE Guideline NG84, 2023, recommends limiting acute headache medication to less than or equal to 10 days per month and initiating prophylaxis after greater than or equal to 2 months of overuse. CGRP monoclonal antibodies, irenyumab 140 mg monthly, demonstrate a 45% responder rate, greater than or equal to 50% reduction in headache days, in MOH patients refractory to withdrawal, Mirage MOH, 2023. Mortality attributable to MOH is low, 0.3% 5-year all-cause mortality, but functional disability, MIDAS greater than or equal to 21, persists in 38% of patients after 1 year. Overview and epidemiology. Medication overuse headache, MOH, is defined by the International Classification of Headache Disorders, 3rd edition, ICHD-3, as a secondary headache disorder precipitated by regular overuse of acute headache medications. The ICD-10-CM code for MOH is G44.41. Global epidemiologic surveys estimate a prevalence of 1.5%, 95% CI 1.21.8%, in the adult population, translating to roughly 115 million individuals worldwide. World Health Organization, 2023. In high-income regions, prevalence rises to 2.1%, Eurohead, 2022, whereas low-income regions report 0.9%, African Headache Consortium, 2021. Among patients presenting to tertiary headache centers, MOH accounts for 30% of chronic daily headache (CDH) cases, making it the second most common CDH etiology after chronic migraine (CM). Age distribution peaks at 3.545 years, mean equals 38 plus or minus 9 years. Sex ratio is 3:1 female to male, reflecting higher analgesic consumption in women, RR equals 1.8. Racial analyses in the United States show prevalence of 1.6% in non-Hispanic whites, 1.4% in African Americans, and 1.2% in Hispanic populations, NANS, 2022. Socioeconomic status correlates with MOH risk. Individuals in the lowest income quintile have an adjusted odds ratio, hour, of 1.9, 95% CI 1.52.4, compared with the highest quintile. Pathophysiology. MOH arises from neuroplastic changes induced by repetitive activation of the trigeminovascular system. Acute analgesics, particularly triptans and opioids, provoke sustained release of calcitonin gene-related peptide, CGRP, and substance P from trigeminal afferents, leading to central sensitization of second-order neurons in the trigeminal nucleus caudalis. Molecular studies demonstrate upregulation of NMDA-type glutamate receptors, NR2B subunit increase of 32% in post-mortem brainstem tissue of MOH patients, and downregulation of the inhibitory GABAA receptor alpha-2 subunit, -18%. These alterations lower the threshold for pain transmission, manifesting as daily headache. Genetic predisposition contributes approximately 12% of MOH variants, heritability estimate H superscript 2 equals 0.12. Polymorphisms in the CYP2C92 allele, frequency equals 0.14 in Caucasians, correlate with slower metabolism of NSAIDs, increasing exposure and risk, or equals 1.6. Variants in the serotonin transporter gene, 5-HTTLPRS allele, are overrepresented in MOH cohorts, 41% versus 22% controls, p equals 0.004, suggesting serotonergic dysregulation. Clinical presentation. The hallmark of MOH is a daily or near-daily headache occurring on greater than or equal to 15 days per month for 3 months, superimposed on a pre-existing primary headache disorder, most commonly migraine. 71% of MOH cases. The most frequent symptom is bilateral pressing or tightening pain, present in 84% of patients. Associated features include, atypical presentations are more common in older adults, greater than 65 years, and immunocompromised patients. In the elderly, MOH may manifest as new-onset dull occipital pressure without classic migraine features, present in 19% of elderly MOH cohorts. Diabetic patients often report reduced pain intensity, mean VAS equals 4.2 plus or minus 1.1, but higher medication consumption, average 18 plus or minus 4 days per month. Immunocompromised individuals, e.g., HIV positive, may develop MOH after use of opioid analgesics for opportunistic infection pain, with a higher incidence of medication-related adverse events. AE rate equals 22% versus 9% in immunocompetent. Key points: nausea or vomiting, 46%. Photophobia, 38%. Phonophobia, 34%. Neck muscle tenderness, 27%. Diagnosis. 1. History. Confirm headache greater than or equal to 15 days per month for 3 months. Document acute medication use, greater than or equal to 10 days per month for triptans, ergotamines, opioids, or greater than or equal to 15 days per month for NSAIDs/acetaminophen. 2. ICHD-3 criteria, apply the following. 3. Exclusion of secondary causes, perform targeted investigations, see below. 4. Confirmatory biomarkers, serum CGRP greater than 100 pg/ml supports MOH but is not mandatory. Key points: A headache present on greater than or equal to 15 days per month for 3 months. Beat regular overuse of one or more acute headache medications for 3 months. C. Not better accounted for by another ICHD3 diagnosis. CBC, hemoglobin 1216G/DL, female, /1318G/DL, male, WBC 410x10/L. Management and treatment. Patients presenting with severe withdrawal headache, 8/10 VAS, may require short-term rescue therapy. Emergency stabilization includes key points, monitoring, vital signs, oxygen saturation, and pain scores every 2 hours. For fluids, 0.9% saline at 1 L/hour for the first 2 hours to mitigate dehydration from vomiting. Rescue analgesia, for acetaminophen 1G, max 4G/24. References. 1. Ashina S. et al. Medication Overuse Headache. Nature Reviews. Disease Primers. 2023, 9-15. PMID, 367325518, https://pubmed.ncbi.nlm.nih.gov/367325518. DOI 10.1038/S41572-022-00415-0. 2. Gosalia H. et al. Medication Overuse Headache, a Narrative Review. The Journal of Headache and Pain. 2024, 25, 189. PMID, 388168828, https://pubmed.ncbi.nlm.nih.gov/388168828. DOI 10.1186/S1014-024-01755W3. Rizzoli P. Medication Overuse Headache. Continuum, Minneapolis, Minnesota. 2024, 30, 2379-390. PMID, 385684889, https://pubmed.ncbi.nlm.nih.gov/385684889. DOI 10.1212/con.00000000000001403. 4. Oliveira R. et al. CGRP Targeted Medication in Chronic Migraine, Systematic Review. The Journal of Headache and Pain. 2024, 25, 151. PMID, 385758868, https://pubmed.ncbi.nlm.nih.gov/385758868. DOI 10.1186/S10194-024-01753Y5. Nguyen J.T. et al. Medication Overuse Headache. Physical Medicine and Rehabilitation Clinics of North America. 2025, 36, 4801-807. PMID, 4116787, https://pubmed.ncbi.nlm.nih.gov/4116787. DOI 10.1016/J.PMR.2025.07.006. 6. Raggi A. et al. Hallmarks of Primary Headache, Part 1 Migraine. The Journal of Headache and Pain. 2024, 25, 1189. PMID, 394825575, https://pubmed.ncbi.nlm.nih.gov/394825575. DOI 10.1186/S10194-024-01889X. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.